Hi everyone, good afternoon and welcome to this session. And I hope you all attempted the exam before joining the session. So, which of the following factors is responsible for non-scarring alopecia in patients? So, alopecia areata, telogen effluvium, androgenetic alopecia, and frontal fibrosing alopecia. So, which of these causes non-scarring alopecia? So, alopecia areata, telogen effluvium and androgenetic alopecia, they all cause non-scarring alopecia. Frontal fibrosing alopecia is a type of scarring alopecia. Frontal fibrosing alopecia is a type of lichen planus. It is one of the variants of lichen planus, and this causes scarring kind of alopecia. Right? So you all are right. So here the answer should be B, which is 1, 2, and 3. So quickly, I wanted to revise this topic of alopecia. So when you have alopecia, you broadly divide it into two categories: scarring and non-scarring, right? Now, when you have scarring alopecia, you have to remember three main causes. One is DLE, second is pseudopelade of Brock, and third is lichen planus. Now, when I say lichen planus includes frontal fibrosing alopecia, as has been given. It also includes Graham Little Picardy syndrome, and it also includes follicular lichen planus. So any of this may be given, but they are all forms of lichen planus, right? Now, when we are talking about DLE, so first I'm discussing scarring alopecia. So when we have DLE, you would be given either perifollicular plugging, or what sign is associated with DLE? Pseudopelade of Brock, you rightly said, is associated with footprint in snow appearance. So it is associated with footprint in snow appearance. It is an idiopathic condition where you do not see any inflammation, you do not see anything, you just see patches of cicatricial alopecia, and the appearance is footprints in snow appearance, right? But what is it with DLE? What sign is associated with DLE? With DLE, we have perifollicular plugging, which is called as carpet tack sign or tin tack sign. Carpet tack sign or tin tack sign is associated with DLE, right? So this is broadly what you're asked about, scarring alopecia. Now, when we talk about non-scarring alopecia, we further divide it into various forms, right? So the most common non-scarring alopecia is what we call as effluviums. So in effluviums, you see diffuse hair shedding, right? Now, effluviums is further divided into two categories. It can be anagen effluvium or telogen effluvium. Now, where do we see anagen effluvium? Where do you see anagen effluvium? So I'm quickly revising this topic of alopecia and discussing all the important questions which are asked in this. What is anagen effluvium associated with there? So telogen effluvium is something that you see after an insult, some infection, some prolonged infection, pregnancy or something, and 2 to 3 months after that, you see hair fall happening. Right? So that is telogen effluvium. You have to counsel and you have to give biotin hair. Right? Anagen effluvium is something that you see associated with chemotherapy or radiotherapy where there is global alopecia. So you see a global alopecia here. Right? The second form of non-scarring alopecia is patterned alopecia. Patterned alopecia can be seen in males as well as females. In males, I call it male androgenetic alopecia, and in females, it is called as female androgenetic alopecia. Male androgenetic alopecia, you see bitemporal recession, you see vertex balding, which is seen, and the scale which is used is called as Norwood-Hamilton scale. Norwood-Hamilton grading or Norwood-Hamilton staging is seen. How do you treat? You give minoxidil and you give finasteride here, right? So this is patterned. You see bitemporal recession with vertex balding. In female androgenetic alopecia, it is the widening of central parting that you see. And in female androgenetic alopecia, the classification is called as Ludwig's classification. So in there is Norwood Hamilton, and here it is Ludwig's classification, and you see Christmas tree appearance. Christmas tree appearance is seen, right? So these are two types of non-scarring alopecia. The third kind of non-scarring alopecia is patchy alopecia, right? In patchy alopecia, we have alopecia areata. Alopecia areata is autoimmune. Here you see patches of alopecia which are asymptomatic, autoimmune, and you see, very importantly, exclamation mark here. Exclamation mark here is seen. Right? The second in patchy alopecia is trichotillomania. In trichotillomania, what is the sign that you see? What is the sign that you see in trichotillomania? Yes, with trichotillomania, you see hair of varying lengths. You see broken hair of varying lengths. So you see a patch where you see that there are different hairs of varying lengths. And you see frituxime. Very importantly, here you will get some psychiatric history. Patient is isolated, something like that would be given, right? The third kind of patchy alopecia would be tinea capitis, in which you would see KOH being positive. You can see some scales. Yes, you're right. You also see perifollicular hemorrhages here, because here the patient is pulling the hair. So there are perifollicular hemorrhages, right? And last in patchy alopecia is moth-eaten alopecia. Moth-eaten alopecia is seen with syphilis. Clear? So this is in brief about the various kinds of alopecia that you get in the exam and their important features. I hope you have no confusion about any of these. In case there is something, you can ask it right away or even later. That's your choice. Okay? So moving on to the next question. A 5-year-old boy presents with, I'm marking the important things which I think will help me answer the question. Hypopigmented macules distributed along the lines of Blaschko. The lesions are asymptomatic, has been present since birth, no progression or associated symptoms. So what do you think it is? I thought you would get confused with vitiligo, but I'm glad that you didn't. Yes, the answer here would be nevus depigmentosus, and that, so see, let's quickly talk about all of this. Nevus depigmentosus is a condition where you see hypopigmented macules along the lines of Blaschko's. They are asymptomatic, present since birth, and no history of progression is there. So whatever this question is mentioning is a classical description of nevus depigmentosus, right? Now, why is it not vitiligo? In vitiligo, usually it is not present at birth. Second, the lesions progress, they are not stable. Third, then they are usually depigmented. What kind of vitiligo can you confuse it with? Any idea? What kind of vitiligo can you confuse with nevus depigmentosus? General vitiligo or vitiligo vulgaris is not something that you'll confuse with the vitiligo. Yes, it is the segmental vitiligo which can be confused with nevus depigmentosus. And there was a question last year. So remember, segmental vitiligo or even congenital vitiligo may not be exactly present at birth, usually progresses, lesions are depigmented, and if you do a Wood's lamp, it shows positive Wood's lamp fluorescence, which you do not see in nevus depigmentosus. So I'm telling you the important differentiating features here. Coming to nevus anemicus. Nevus anemicus is a pharmacological nevus, right? Now, nevus anemicus and depigmentosus present similarly. It is dioscopy which helps me differentiate between the two. Okay, so you might as well say that this is nevus anemicus also, but remember, more commonly we have nevus depigmentosus only when the question mentions that on dioscopy lesion merges with normal skin. then you answer nevus anemicus. That is the purpose of giving these options to you here. I'm happy you didn't get confused, but you should know this. Piebaldism, there is a question later, so we'll discuss it there. Right? So this is classical nevus depigmentosus, hypopigmented lesions along the blush-course lines. Clear? Can be confused with pityriasis alba. Okay, so no, you cannot and you should not confuse it with pityriasis alba because pityriasis alba is scaly. Right? It is not like this. It is not present since birth. You see numerous lesions on the face. It does not follow the lines of blush course. Right? So none of these features match pityriasis alba, and so we will not confuse it with that. Okay? Also, pityriasis alba is seen more commonly in atopics. Right? Good. Coming to the next question. So since I said that we'll be talking about this, so what is this condition that I've given you and what is the answer here? So what is this condition that I've given here? A 16-year-old male presenting with irregular hypopigmented macule on forehead, anterior part of the body. You see a white forelock, you see V-shaped leukoderma on the mid-forehead, you see small spots of hyperpigmentation within the hyperpigmented lesion. With genetic abnormality, this is piebaldism. So this is piebaldism. You have lesions in the distribution of a pie. You see depigmented lesions with islets of pigmentation with white forelock of hair. That is a triad of piebaldism. Piebaldism is because of, it is not Waardenburg syndrome. There is no other systemic feature which is mentioned here. So I will be talking about different features of Waardenburg VKH syndrome. So we'll get back to it there. So this piebaldism is associated with mutations it is because of mutations in the KIT gene. So I guess you're getting it confused with NOLA3 gene because you're thinking of Waardenburg syndrome, but this is not there. This question and the description is only matching with piebaldism. It's a V-shaped lesion or a pie-shaped lesion with depigmented lesions with some islets of hyperpigmentation with white forelock of hair. You have to just think of piebaldism unless I give you other systemic features or other associations with it. Right? So we'll come back to those associations. So this is piebaldism, and this happens because of mutations in the KIT gene, which is on chromosome 14. You're right. Right? A 60-year-old female presents with eczematous itchy lesions. Biopsy revealed a subepidermal cleft. DIF shows linear C3 and IgG deposition. What is the most likely diagnosis here? Any confusion with this question? I always tell students pemphigus is my favorite topic. And I really want that you all should be able to get pemphigus easily. Good job. So everybody is answering the same. Yes, this is bullous pemphigoid, and I have all the reasons to mark it because eczematous itchy lesion is a feature of bullous pemphigoid. Subepidermal cleft is telling me it is a subepidermal immunobullous disorders. Linear IgG and C3 is further nailing it down. Now let's look at the other option, pemphigus vulgaris, no eczematous lesions, no subepidermal cleft, no linear C3 IgG deposition. DH, again, you do not see linear C3 and IgG deposition. What is the kind of, because see, a DH can present with eczematous itchy lesions, right? And you can see subepidermal cleft here also. But why is this not DH? Because of what I see in DIF. Yes, but I may not give you celiac disease. So what is seen in DIF of dermatitis herpetiformis? Because in this question only that is helping me differentiate between DH and bullous pemphigoid. Yes, you see papillary tip immunofluorescence. You do not see a linear immunofluorescence. You see papillary tip immunofluorescence of IgA. So that is what is helping me differentiate, right? So you should get these important points here. Yes, there is neutrophilic, but again, I've not mentioned neutrophil or eosinophils in the question, so you will not be able to differentiate between them. So in this question, it is the DIF which helps me differentiate, because bullous pemphigoid will present with linear C3 and ITT deposition. Now, I quickly wanted to revise this topic with you. So I'm giving you some tables, some important questions which are asked. So broadly, you should be able to differentiate between intraepidermal and subepidermal, right? We'll talk about that. In intraepidermal, two main categories, pemphigus foliaceus and vulgaris. So foliaceus is F, F is first. So desmoglein 1 is the target antigen here. In vulgaris, it is desmoglein 3. It can also be desmoglein 1, but predominantly it is desmoglein 3 here. The separation happens at the level of stratum granulosum. So it is a subcorneal bulla that you see here. The bulla is subcorneal. There is no mucosal involvement in foliaceous. Then here, the bulla is suprabasal. It is above the basal layer. Because in foliaceous, the bulla is subcorneal, it ruptures easily. And so what do you see? You see mainly crusted erosions here. Whereas in pemphigus vulgaris, you see flaccid bulla. Flaccid bulla is very, very typical of pemphigus vulgaris, right? In pemphigus foliaceous, as you rightly pointed out, you see skin involvement, but there is no mucosal involvement. Here, in 100% of cases, you would see mucosal involvement to be there, right? So mucosal involvement, if present, think of pemphigus vulgaris. No mucosal involvement, crusted erosions in seborrheic areas, think of foliaceous, right? So pemphigus foliaceous and vulgaris, this is very, very classical. So this is how you differentiate. How do you differentiate between pemphigus and pemphigoid? So pemphigoid is a prototype of subepidermal immunobullous disorders, where the split is happening at the level of dermoepidermal junction, right? Now here, the kind of bulla that you see is tense. You see tense bulla, right? And you see Minar being positive in pemphigus and absent in pemphigoid group. So what is Minar? Mucosal involvement, intraepidermal bullae, Nikolsky sign, presence of acanthocytes or Zank cell, and row of tombstone appearance. All of this is seen in pemphigus, and especially pemphigus vulgaris, and not seen in pemphigoid group of disorders. So flaccid and tense bullae, Minar being positive in pemphigus, absent in pemphigoid group. Right now, remember one more thing about pemphigoid group, especially bullous pemphigoid, that it has a pre-bullous stage, in which the patient can present with itchy, urticarial, or eczematous lesions. Itchy, urticarial, or eczematous lesions may be seen. Right? So I hope you're clear and you would be able to differentiate between these categories. Now, another important thing is, if you do a biopsy in pemphigus group, what will you see? In pemphigus group, you would see a suprabasal or subcorneal split. As I told you, in pemphigoid group, you see a subepidermal split here. If you do a DIF, you see fish net pattern of immunofluorescence here. Whereas here you see linear IgG and C3 deposition. Clear? So these are all important features which help me differentiate between pemphigus and pemphigoid. Row of tombstone is seen in pemphigus group. Fishnet pattern seen in pemphigus group. Clear about this? I'm sorry about this table, but I think I'll help you out. So here I was trying to tell you about the major antigens which are involved. So in bullous pemphigoid, it is BP 180 and BP 230, also called as BP antigen 2 and 1. Pemphigoid gestation is same. Linear IgA disease has BP antigen 1 and linear LAD antigen also. EB equisita and bullous Eli both have antigen at collagen 7, which is the lowermost thing. So, if I have to differentiate between EB, listen to my question carefully. If you have to differentiate between EB and BP, what do you do? How do you differentiate EB versus BP? Both of them can present with tens bullae. EB here is epidermolysis bullosa acquisita and bullous pemphigoid. Both of them can present with tens bullae. If you are confused, you're absolutely right. You do a salt split technique. What is a salt split technique? You take the sample and you put it in 1 molar NaCl. There is a split which happens at lamina lucida because that is the weakest layer of my dermoepidermal junction. If the fluorescence happens at the roof of the bulla, it is BP. If it is happening at the floor, it is EBA. Right? So roof is bullous pemphigoid, floor is EBA. E is earth, earth is floor. So remember like that. Right? Clear now? So this is important. The last thing which is important here, sometimes they tell you to mark the diseases based on the level of antigens that they are present. So this is a small mnemonic. First we pray, then can eat. So topmost is pemphigus foliaceus or first. V is vulgaris or pemphigus vulgaris. P is pemphigoid or bullous pemphigoid. Then can eat. C is cicatricial pemphigoid and E is EBA. So first we pray, then can eat. So this is the order in which various disorders are there in the skin based on their target antigen. Right? So this is again important. So this is a very, very important topic and you should be able to understand and answer these questions. I already told you about the DIF findings. Any questions you have regarding that topic, please put it in the chat box. I'll try to answer. Okay, moving on to the next question. A 10-year-old child develops round, firm, painless bumps on the face. All are true about this disease except. So what's the answer here? What is this disease and what is the answer? So yes, so what should be the correct answer? Here the answer is option B because yes, this is a case of molluscum contagiosum. Molluscum contagiosum is caused by a virus called as molluscum contagiosum virus, which belongs to a family of mollusci pox virus, which are largest known DNA viruses. So these are not RNA viruses, these are largest known DNA viruses. How do you know this is molluscum? When you look at the lesion, you have painless lesions on the face. And if you see the lesions, you see a central umbilication. You see central umbilication, which gives away that it is molluscum contagiosum. So central umbilication is a classical thing about molluscum contagiosum. DNA viruses, pox virus, umbilicated lesions. Yes, it spreads from direct skin to skin contact. We know that auto-inoculation is seen, and that is what presents to me with pseudo-Koebner's phenomena. So you see pseudo-Koebner's hairs, which happens because of auto-inoculation. Lesions are not generally seen in palms and soles. That's also correct. Most commonly, the lesions are seen on face. It's not that they cannot be there, but generally they are not present on palms and soles. Clear? So molluscum contagiosum is important. You usually can get a family history. Okay, what do you see on histopath? What do you see on histopath of a molluscum contagiosum patient? Is there a particular histopath feature which is classical for this? Absolutely right. So why do people say that you're not well prepared? You know almost everything. So this is HP body or Henderson-Peterson bodies that you see if you do a histopathology. These are eosinophilic inclusion bodies which are seen in these patients. Wonderful. Right? So that finishes our molluscum. Coming to the next question, a 3-week-old neonate is brought to OPD with facial rashes exacerbated by sun exposure. And this is a neonate. You see erythematous scaly papules around the eyes. Maternal history includes positive anti-ROLA antibodies. Which congenital cardiac anomaly is associated? What is this condition? And what is this appearance called as? This is heart block. Wonderful. What is this condition and what is this characteristic appearance called as? But this is neonatal LE or neonatal lupus erythematosus? Yes, because of transplacental transfer of maternal antibodies. And what is this sign called as? This sign that you see, periocular erythematous scaly eruptions, which helps me clinch a diagnosis here. So this is called as owl eye sign or raccoon sign, right? So this is called as owl eye sign or raccoon sign, where you see these erythematous scaly eruptions. Patient looks like it's an owl eye. Owl eye, eye mask or raccoon eye. There is congenital heart block that is there, and the patient has positive Rho antibodies. Clear? So it's a type of LE called as neonatal LE. Right. Okay, this we've already discussed. So quickly tell me the answer. A 35-year-old woman presents to you with hair loss for past 3 months. There was a positive COVID-19 few months ago. So positive COVID-19 few months after that, patient is having hair fall. We already discussed it. There is an insult, and 2-3 months after that, patient presents with hair fall. It is telogen effluvium, and you manage it by counseling and giving biotin to the patient. Right? Obviously, it's not tinea capitis, trichotillomania, or FAJ because we've already discussed that. Clear? Biotin, yes. Okay, next question. Annular lesions are seen. So dermatology is all about description, as I always say. And so there are a lot of annular lesions that we see. So where do we not see annular lesions? So that is what I expected, and that's okay. I knew there would be confusion between B and D. Now, so obviously we all know that tinea corporis presents with annular lesions with central clearing, right? Pityriasis rosea, again, we know we have annular lesions with peripheral collarette of scales. This we all know. How about urticaria pigmentosa? Did anywhere in urticaria pigmentosa we talked about annular lesions? So urticaria pigmentosa, if you all remember, is a form of cutaneous mastocytosis which presents with urticarial lesions. And urticarial lesions are not annular. They are wheals. They are erythematous, edematous, itchy, evanescent, but they're not annular. So here the answer would be urticaria pigmentosa. Porokeratosis is a type of inflammation which I'm sure you must not have read because I know it's not for your level, but this is the kind of question you get. But you have read about urticaria pigmentosa, and urticaria pigmentosa, nowhere did we mention that it presents with annular lesions. Porokeratosis, on the other hand, presents with annular lesions, and these annular lesions show a periphery which is slightly raised, atrophic, and violaceous, right? So this can present with annular lesions, but urticaria pigmentosa does not present with annular lesions, right? So quickly, here are the diseases that can cause annular lesions. You do not need to know the whole table. I'll just tell you the important ones. So there are a lot of annular erythemas. They're named as annular erythema, which present with annular erythematous lesions. So erythema migrans, erythema multiforme, then even granuloma annulaire, we've discussed, can present with annular lesions. Urticaria sometimes can present with urticaria, but urticaria pigmentosa does not present with annular lesions. So again, this table, I would not say that you have to know everything. No tinea corporis, no pityriasis rosea. Okay, then a few other. Annular lesions with central crusting. What is it? This we have discussed, and this you should be knowing. Annular lesions with central crusting. This is seen with cutaneous leishmaniasis. So this is also something that you should be knowing. So central clearing is tinea corporis. Central crusting is cutaneous leishmaniasis. Yes, tinea circinata can present with circular lesions. Lupus vulgaris will present with annular lesion with central atrophy. So if it is central atrophy, I call it lupus vulgaris. Central clearing, I call it tinea. Cutaneous leishmaniasis, central crusting. Tinea circinata can present with annular lesions. Right? So here the answer would be urticaria pigmentosa. And then last, recently there was a question on granuloma annulare. So granuloma annulare also presents with annular lesions, as the name suggests. The borders here are granulomatous and center and surface is absolutely normal. There is no crusting, no scaling, nothing. Right? Yes, you see it in patients who are diabetic, who are hypothyroid. So this is the population that you see these lesions in. Right? So these are some of the common annular lesions that you study in dermatology. Moving on to the next question, a school-going child who had applied henna comes to dermatology OPD with the following lesion. The mother complains that he has a habit of scratching her hand whenever she is studying. What is the diagnosis for this child? So see, obviously this is ruled out and this is ruled out. You do not see depigmented lesions. Polymorphous light eruptions is because of sun, and you see small erythematous to skin-colored papules in sun-exposed areas. So here I know the confusion is between A and B. Now look at the lesion here. So lesion has a very bizarre appearance. It is something like this. Why would a contact dermatitis present with something like this? So when you apply henna, it will happen at the site of henna application, can also spread beyond, but it will not present in some bizarre configurations. So if you see bizarre configuration of lesion with a habit of scratching her hand, this points towards dermatitis artifacta. So, dermatitis artifacta is self induced. Some people have a tendency of self injuring themselves or inflicting self injury. When they do it, it will be in bizarre but a very particular shape, which cannot be linked to a dermatitis or to something more specific. So when you see such bizarre geometrical configurations, you think of dermatitis artifacta, and especially if there is habit of scratching her hand. A contact dermatitis to henna is common, but you will see it at the site of henna application. You do not see any henna application here, right? So this is not contact dermatitis to henna. Henna is just being given to confuse you. Clear on this? Okay, next question. A 4-year-old child presents with sores in the mouth, rash on hands and feet. What is the causative organism? So this is quite easy, I guess. Yes. So this is hand, foot, and mouth disease, right? Or HFMD. You have oral erosions, you have hands and feet involved. This is the, I think, easiest to diagnose in dermatology, as the name suggests, right? Namradhya disease ka, so hand, foot, and mouth disease in a child. It is caused by Coxsackie A16 virus, right? Pox virus we know causes molluscum. Human papilloma virus causes warts. Herpes virus we know causes various kinds of herpes. So here the answer is Coxsackie A16, and this disorder is HFMD. Okay, next question. A 30-year-old woman develops dusky red to brown patches on her arms and legs, as shown in the image below. After taking a specific antibiotic, the patches are not painful, slightly itchy, leave hyperpigmentation. And this is the most important line. She had a similar reaction to the same medication in the past. If this line is given to you, same reaction, same place, same drug, this is fixed drug eruption. You do not have to even look at other options. So, same drug, same place, and same reaction. So, this is fixed drug reaction. It happens after intake of an antibiotic or any drug. Patient develops an itchy lesions, and very typically it heals with pigmentation. It heals with pigmentation, and this is very classical, a circular pigmented lesion on a particular area of the body. Post-inflammatory hyperpigmentation will not recur. It is not like in planus pigmentosus or melasma, right? So I hope there is no confusion here. This is a very, very straightforward question. Okay, where is the apocrine gland present? Now, so we have three types of glands. So one is sweat and the other is sebaceous. Sweat gland is further divided into eccrine glands and apocrine glands, right? The eccrine gland is present all over the body and is more on palms and soles. This is the gland which is responsible for sweating. Apocrine glands, on the other hand, is present in axilla, groin, breast, and umbilical area. And this is responsible for body odor. Right? Sebaceous glands, on the other hand, is seen in seborrheic areas, which are my scalp, face, and upper part of the body, and these secrete sebum or oil. So, apocrine glands, A for A, and they are usually appearing at adolescent age group. So, again, A, and they have an adrenergic nerve supply. So, again, A. So, all A's are associated with apocrine gland. So, apocrine gland is seen in axilla. Palms and soles, eccrine glands. Face and scalp, you have both eccrine and sebaceous glands. So, here the answer would be axilla. Clear? So these are three kinds of glands. You should know their distribution. You should also know that eccrine gland has eccrine secretion, apocrine has apocrine secretion, and sebaceous gland has holocrine secretion. Both apocrine and sebaceous gland become activated during adolescence, whereas eccrine gland is activated at birth only. Right? Here? Good. There is no confusion here, thankfully. A 28-year-old priming gravida delivers a baby at 30 weeks of gestation. The newborn skin appears very thin and translucent. Which layer of epidermis is absent in the baby? So if there is a preterm baby, which layer is absent? So preterm baby, it is CADD. Thankfully, basal layer bacha hua hai. Yes, so most of you are right. It is stratum corneum because my skin forms like this from stratum basale, stratum spinosum, stratum granulosum, and stratum corneum. So my stratum corneum is the last layer to form. Stratum basale is the germinative layer from which my epidermis forms. So if a baby is born preterm, ये यहीं रुक जाएगा, and so the stratum corneum will not have been formed, and that is why the skin will appear thin and translucent. Okay, so the layer which will be absent in a preterm baby would be stratum corneum, right? So you should know the layers of the epidermis. Come, let's get sunburnt. Corneum is topmost but is formed the last. Basal layer is the lowermost layer, and it is the germinative layer of the epidermis. So there should be no confusion here. The answer would be stratum corneum, correct? Okay. During a dermatology demonstration on Koebner's phenomena, the professor also discusses pseudo-Koebner's. Which of the following condition typically shows a pseudo-Koebner response? So there is Koebner's phenomena and there is pseudo-Koebner's phenomena. Pseudo-Koebner's is seen with warts and molluscum because here it is happening because of auto-inoculation, right? Whereas true Koebner's is seen with lichen planus, psoriasis, and vitiligo. Vitiligo, psoriasis, and lichen planus causes true Koebner's, and pseudo Koebner's is with warts and molluscum. So here the answer would be warts, right? Yes. So this is very important. Please memorize this. LPV or whatever you like to call it causes true, and warts and molluscum causes pseudo Koebner's. A 27-year-old woman presents with complaints of severely itchy rashes all over her body that developed after she used a hot tub in a hotel. So itchy rashes with hot tub in the hotel. You have multiple monomorphic papules with pustules predominantly over trunk and buttocks, which is the most likely causative organism. So this is hot tub folliculitis. Hot tub folliculitis typically presents like this. You take a bath in a in a public place, in a jacuzzi, in a hot tub in the hotel, and you develop multiple monomorphic papules or pustules over the hair follicle. This is called as hot tub folliculitis, and the causative agent is Pseudomonas aeruginosa. So it is a bacterial infection caused by Pseudomonas, and the term for it is hot tub folliculitis. Now, a lot of you told me Corynebacterium minutissimum. What does that cause? What is the infection caused by option number C? I see there is a lot of confusion here. Staphylococcus aureus and pyogenes. What do they cause? They cause all kinds of pyoderma. Impetigo, folliculitis, cellulitis, erysipelas, all of this is caused by Staphylococcus aureus and pyogenes. Corynebacterium minutissimum causes erythrasma, which will present with well-defined erythematous lesions on underarms. It can present in groins, on the interdigital web space, and it would show coral red fluorescence. Right? Hot tub folliculitis is caused by Pseudomonas aeruginosa. What else does Pseudomonas cause? Pseudomonas causes few infections in the skin. What are the, apart from hot tub folliculitis, what is a common infection which is caused by Pseudomonas aeruginosa? It causes green nail syndrome. Just saying ecthyma won't suffice. What kind of ecthyma? Because ecthyma is caused by 3 different organisms. Ecthyma contagiosum is caused by virus. Ecthyma infectiosum is caused by streptococcus. It is the ecthyma gangrenosum, which is caused by Pseudomonas. Ecthyma gangrenosum is something which is caused by Pseudomonas. Green nail syndrome, hot tub folliculitis, this is all caused by Pseudomonas. So there should be no confusion here. This is the classical description of hot tub folliculitis. Okay, a woman presents with pruritic rash on elbows and buttocks, which is the extensors area, with recent diagnosis of gluten-sensitive enteropathy. On immunofluorescence, you see IgA deposition. What is the most likely diagnosis? So this we have already discussed. You're all right. This is dermatitis herpetiformis. So dermatitis herpetiformis is associated with diarrhea or gluten-sensitive enteropathy. It presents on extensors with itchy lesions. You have IgA deposition in the papillary tip. Patient has gluten sensitive, and the patient responds to withdraw gluten and give dapsone. So D is very favorite with dermatitis herpetiformis. So dermatitis herpetiformis, diarrhea, dapsone, this is all important for dermatitis herpetiformis. When you say you withdraw gluten, what do you withdraw? You withdraw BROW or BRO, barley, rice, oats, and wheat. But you are allowed to take maize and rice or MR. Right? So DH is again very important. Look at the image. They have given you papillary tip immunofluorescence. And this is IgA based. Right? What is the target antigen in dermatitis herpetiformis? What is the target antigen here? I didn't talk about the target antigen. This is IgA's antibody. So IgA is the antibody, but what is the antigen against this, which this antibody is being formed? So this is epidermal tissue transglutaminase. Epidermal tissue transglutaminase. Yes, right. So don't get confused. Now, DH is different from other subepidermal disorders. It is not BP antigen or anything. It is epidermal tissue transglutaminase, which is the target antigen here. Right? So this is all about DH, and you should be knowing DH pretty well. Which of the following conditions is not included in syndromic management for males? So we know in STIs, you should know about all the syndromic managements. So there are different syndromic management. First is for urethral discharge. Second is for vaginal discharge. Third is for ulcer, which is for syphilis. Fourth is ulcer syphilis, which is benzathine penicillin intolerant. And fifth is herpetic ulcer. Sixth is lower abdominal pain. Seventh is bubo. And eighth is anogenital discharge. Eighth is the new kit which is there for syndromic management. Yes, I will repeat. Just give me 1 second. Let me finish this off. So, which is not included in syndromic management for males? Urethral discharge is, genital discharge is, inguinal swelling is same as bubo. So, that is lower abdominal pain is not included for males because lower abdominal pain is a feature of pelvic inflammatory disease which you see in females, not males. So lower abdominal pain, the kit is for females, it is not for males. So here the answer would be option D. These are all different kits which are available. Out of this, anogenital discharge is the new kit which is brown in color. Right? So you should be knowing about these STD kits. So the target antigen in dermatitis herpetiformis is epidermal tissue transglutaminase. Now, transglutaminase is also seen in endomysial as an endomysial antigen. They cross-react with the epidermal tissue transglutaminase, and that is why you have gluten-sensitive enteropathy associated with DH here. Right? So it is epidermal transglutaminase, also called as TTG. Epidermal TTG. Clear? Clear about this genital ulcer, this syndrome also? Done. So we'll move on to the next question. A 40-year-old woman presents with painful pruritic lesions 2 days after developing fever. History of similar lesions in past associated with fever which resolved gradually. What is the likely diagnosis here? What am I seeing? So what do you see here? You are seeing coalescing vesicles. Yes, you are seeing coalescing vesicles which are present at vermilion border of the lip. And these are present after fever. So after fever, recurrent coalescing vesicles at the vermilion order of the lips. This is herpes labialis. Herpes labialis is caused by HSV, mostly 1. So why is it varicella? Varicella causes chicken pox or herpes zoster. This is not varicella. Herpes labialis is also referred to as cold sore. That was the confusion here. Herpes labialis is also referred to as cold sore, and so this is a case of herpes labialis. So you all said it right, this is herpes labialis, but herpes labialis you should know is also called as cold sore. Molluscum we have already discussed. What is vitiligo? Vitiligo is again caused by herpes and is called as herpetic vitiligo when you see lesions on fingertips, usually seen on pathologist hands. Fingertip, you see vitiligo is herpetic vitiligo, which is seen at the fingertips of nurses, of pathologists. because of HSV infection on the fingertips, right? Since here it is present on the lips, we call it herpes labialis. It is caused by HSV1 and also called as cold sore. Herpes labialis is recurrent lesions, coalescing vesicles present at vermilion border of the lips, can happen after fever, can happen after stress, can happen after menstrual periods. So a lot of trigger factors are there, right? Since we know here the virus gets latent in the dorsal root ganglion, and that is why this recurrence keeps happening. Clear? Now, which of the morpholine drugs listed below is used as a nail lacquer? Emerolfin, oxyconazole, cyclopyroxolamine, or thioconazole. So it's quite evident morpholine and emerolfin, they match even if we have not studied. So yes, emerolfin is the nail lacquer that is from the morpholine groups of drugs and is used as nail lacquer. So we use the following nail lacquers. There is cyclopyrox nail lacquer, which is a hydroxypyridone derivative. You have emerolfin nail lacquer, which is a morpholine derivative, and we have two more nail lacquers now, efinaconazole, which is a triazole antifungal, and tavabarol, which is a benzoxabarol derivative. So recently there was a question on tavabarol, and that is why I've put this here. You should know efinaconazole and tavabarol, these are newer agents or newer antifungals which are used as nail lacquer. Emerolfin and cyclopyrox we have been using. Cyclopyrox is something which is used daily. Emerolfin is used weekly, right? And nowadays we are also having luliconazole lotion, which we can put inside the nail plate. And so this is also used. But these are all nail lacquers which are used in onychomycosis, right? What is the probable diagnosis of the condition which is affecting the hair and resulting in the following appearance? So what is this appearance? This is trichothiodystrophy. But what is this appearance? How do you know that this is trichothiodystrophy? What is the appearance called as? Yes, tiger tail banding appearance. So it looks like a tiger tail and the bands that you see on tiger's tail. So tiger tail banding appearance is seen with trichothiodystrophy. It is a type of hair shaft defect. So few hair shaft defects which you should be knowing. Trichothiodystrophy, here there is sulfur deficiency, and so patient develops tiger tail banding. Just know the important points. I don't think you should be knowing hair shaft defects at this level, but there has been questions on this, and that's why I'm teaching you this. So sulfur deficient hair, tiger tail banding, which is seen on polarized light microscopy. Along with that, patient can have intellectual and developmental abnormalities. The next option was trichorexis nodosa. Here you have nodes. So the hair breaks at nodes. It can be congenital or acquired, but you basically see nodes here. Monolithics is again a hair shaft disorder where you see beaded hair shafts. You see hair shafts which are beaded and thus resemble a necklace. So beaded hair shaft is monolithics. Nodes is trichorexis nodosa. Next is trichorexis invaginata, in which it is like this. It is invaginating. So like a ball and socket or a golf tee appearance. So trichorexis invaginata shows ball and socket or golf tee appearance and is a feature of Netherton syndrome. This is also known as bamboo hair, you're right. So bamboo hair, part of Netherton syndrome, ball and socket or golf tee appearance, right? Moving on to the next question. A child with a history of night blindness presented to you with the following findings. What is the diagnosis here? So you have night blindness and you see here you've been presented with elbows, which is showing hyperkeratotic follicular papules. So hyperkeratotic, rough-looking hyperkeratotic papules present on the extensors with night blindness. This is referred to as your right phrenoderma, also called as toad skin, and occurs because of deficiency of vitamin A and essential fatty acids. Deficiency of vitamin A and essential fatty acids leads to phrenoderma or toad skin, which presents like this, right? Yes, so this is follicular hyperkeratosis. You're absolutely right. Okay, Next question. A 5-month-old infant presents with large, darkly pigmented lesion on lower back. It has been present since birth, increased proportionately with the body size, and there is hypertrichosis over the lesion. So you have pigmented lesion present at birth with excessive hair growth over this lesion. So what is it? The answer here would be congenital melanocytic nevi. Nevus depigmentosus we've already discussed. Mongolian spot and nevus of Ota or both dermal melanocytic nevi. They do not present with hyperpigmented lesions with hypertrichosis. Mongolian spots are seen in sacral areas with bluish macules. So they will present with bluish macules. Mongolian spots on sacral areas, and nevus of Ota is unilateral in the periorbital area. Both of them present with bluish macules. My next question to you, why can't it be Becker's nevus? Becker's nevus also can present with pigmented lesion. It can also present with hypertrichosis. Then why is it not Becker's nevus? So whether unilateral or not, I have not mentioned. So if the question is open-ended, I can assume it's unilateral or bilateral. But why is it not Becker's? So the clue here is an infant is having it since birth. Becker's nevus develops during adolescence. So though it is an epidermal nevi, it is a nevi which presents during adolescence. So Becker's nevus, you would not see in infancy, you would see it in adolescence. It can present with hyperpigmented lesion with hypertrichosis, but during adolescence. So you are right. Okay, this is how my congenital melanocytic nevi looks like. So you have a deeply pigmented, hyperpigmented lesions with hypertrichosis. Now, if you have CMN, which is present in the trunk, and it is a large lesion, more than 20 centimeter, with satellite lesions, then this is an important precursor for melanoma. So here you have to do a biopsy and you have to rule out melanoma. This is called as giant CMN or giant congenital melanocytic nevi. Right? Yes, it's called as giant CMN. Okay? We were talking about melanoma and here it is. So a 50-year-old construction worker presents to OPD with a black mole on the back as shown in the image, which is the gold standard for diagnosing this condition. So though dermoscopy is associated with melanoma, we use a lot of dermoscopy for melanoma, but the gold standard of diagnosis is biopsy. So whenever you are suspecting malignant melanoma, you can do a dermoscopy and biopsy is the gold standard. So all these tests are done in melanoma. All these are done, but the gold standard is biopsy. If you're just suspecting malignant melanoma, you do a dermoscopy. So you do a dermoscopy in suspected lesions, and if you're still suspicious, you would go for biopsy. However, sometimes dermoscopy gives you a clue that it is not a melanoma. So then you do not go for biopsy. Right? And this is melanoma or malignant melanoma because of the A, B, C, D, E rule. You see asymmetry, you see border changes, you see color changes. So all of this is there. So you have to think of malignant melanoma. Right? Okay. A sexually active male presents with warts on his penis as shown below. Similar lesions present in the anal canal. What is the most likely diagnosis here? This is condyloma acuminata. So condyloma acuminata is another term for genital warts or even for anogenital warts. It is not Bowens, it is not a cancer, it is not hemorrhoid. You are seeing warts, they are saying you warts. So this is anogenital warts. It is, you're right, high risk or low risk. So low risk is HPV 6 and 11 and high risk is HPV 16, 18, 35 and 31. What is giant condyloma acuminata called as? A giant condyloma acuminata is called as, because that is also a lot of time given in the question. It is called as Buschke-Lowenstein tumor. So if suppose you have a large verrucous lesion which has been given here, a large growth which is verrucous, which is shown here, you have to think of Buschke-Lowenstein tumor, which is a giant condyloma acuminata, usually associated with high-risk HPV types. Okay? Clear? Okay. Coming to our old question where you had some confusion. A 25-year-old male presents with uveitis, dysaceusia, scoliosis. On examination, you see areas of leukoderma. Which syndrome is associated with this clinical presentation? Now, what's the answer here? So this is Vogt Koyanagi-Harada syndrome or VKH syndrome. So I'll quickly tell you the important features. So VKH syndrome has a meningoencephalitic phase. So you can have encephalitis, you can have meningitis. Then there are eye symptoms where you have uveitis, choroiditis, and optic neuritis. Okay, and then after that you have poliosis, leukoderma, and alopecia. So here you have uveitis, poliosis, leukoderma with dysaceusia. This is all a feature of, because see, deafness can also happen. So these are all features of VKH syndrome, right? So there is an encephalitic phase, eye involvement with uveitis, choroiditis, optic neuritis, deafness, poliosis, leukoderma, alopecia. If any of this is present, think about VKH syndrome, right? Now, coming to Waardenburg syndrome. So Waardenburg syndrome will have skin lesions which is resembling piebaldism, right? In VKH, you do not have piebaldism. So if you have piebaldism with dystopia canthorum, which is lateral displacement of inner canthi and lower lacrimal puncta, this along with heterochromia of the iris and cochlear deafness, you have to think of Waardenburg syndrome. So Waardenburg clinically in skin will present with piebaldism, but patient will have dystopia canthorum. Heterochromia, look at the eyelids, look at the iris, you'll see heterochromia and the patient can have cochlear deafness. So are you clear now? So this is Waardenburg, right? So piebaldism with these features. Okay. The third syndrome which I provided was Hermansky-Pudlak syndrome, which present with oculocutaneous albinism. And along with that, patient has platelet dysfunction. So bleeding disorders will be there, and there may be lysosomal storage disorders also. So if there is platelet dysfunction given, bleeding defects being given, think of Hermansky-Pudlak syndrome.